Okay, welcome again to our webinar today. I want to wish a happy World Breastfeeding Week and a happy National Breastfeeding Month to you all. I'm going through our intro slides before I officially introduce Ashley Norris. And for those of you who have just joined, please introduce yourself in the chat. This webinar will allow for continuing education. If you want to receive that, then you need to attend 100% of the webinar and submit an evaluation, or you can watch the recording, and then you will need to submit an evaluation and complete and pass a quiz. And we'll get notified when you do those things and send you your certificate within a month or so. Okay, and this is the evaluation. If you want to scan that QR code, I will also put the link into the chat a couple of times throughout the webinar so that you have that, and email it to you after so that you have that evaluation link. And you can find the recordings on our YouTube page and also on our website. We have a new section on our website that lists the recordings that are available for credit. So check that out. We also want to thank our annual partners, especially Maine WIC, for being an annual an annual patron partner for us. And then we also have advocate level sponsors as well. And our webinars coming up, we have in October, the Scoop on Poop, Understanding Infant Defecation. It's super popular and important topic. So register for that. We'll try to remember to include that info in the chat, but also in the follow-up email for you as well. Okay. And again, we were so happy to be able to offer this for free. Some of you did make some donations as well, and thank you for that. If you are interested in making a donation to our 501c3 nonprofit and help support the work that we do all year round, then please consider making a donation to our organization. And I am going to read Ashley's intro once I can find that on my screens. So bear with me here. Just one moment, and I will be able to get to that. I promise. I think what I might have to do is actually stop sharing that screen, and then I can read your intro. Sorry about this. Okay, here we are. Ashley is the heart and soul behind Monadnock Perinatal, serving the Monadnock region of New Hampshire and surrounding communities with compassionate, evidence-based care. A mother of 4, including identical twin boys, Ashley brings personal experience with vaginal and cesarean births, tandem feeding, pumping, and home and hospital settings to her work. She holds certifications as an IBCLC, birth doula, postpartum and VBAC doula, placenta preparation specialist, baby wearing consultant, pregnancy and infant loss advocate, and cloth diaper advocate. Ashley's professional journey began in 2017 when she was supporting friends and family during labor after the birth of her first child. By 2019, after her second child, she began formal training to make birth work her full-time calling. Her lactation care is deeply informed by her own feeding challenges, including early weaning, overactive letdown, reflux, bottle refusal, and feeding multiples. Beyond clinical care, Ashley and her husband Jake live on a little homestead, raising livestock and growing their own food, a lifestyle that reflects her holistic, grounded, and self-sustaining philosophy. She also brings a sense of adventure and resilience to her work, fueled by her longtime passion for demolition derbies. Ashley is deeply committed to building a guiding, knowledgeable, and non-judgmental presence for families, especially those navigating multiples, cesareans, VBACs, and complex lactation challenges, and she truly loves being part of the community she supports. So welcome, Ashley. Thank you for being here, and thank you everyone else for being here. Go ahead and share your screen when you are ready.
Thank you so much for the introduction. Okay, hi everyone. Welcome to this beautiful day that we have here. It's not raining finally in New Hampshire. So I have the presentation today, Twice the Love, Twice the Latch, Helping Families Thrive with Twins. So she just did a beautiful introduction. So I'm going to skip over that part there and go right into the learning objectives. So by the end of this presentation, participants will be able to develop individualized plans for twin or multiple families with access to each baby, parent goals, birthing history, support and feeding realities, protect initiation and supply. So using early contact, frequent milk removal, timely supplementation when medically indicated, and recognize when to refer. So connecting families with lactation consultants, IBCLCs, pediatricians, OTs, SLPs, so speech language pathologists, mental health professionals, doulas, or other specialized support. So disclosures, financial disclosures, I have no relevant financial relationships to disclose. Educational scope, content supports clinical decision-making tools as an IBCLC, so International Board Certified Lactation Consultant, but does not replace individualized medical care. I am also using personal experience as a twin mother myself. Language and inclusivity disclosure. So this presentation primarily uses terms mother, mom, and breastfeeding when discussing pregnancy, birth, and lactation and infant feeding, as these terms are most commonly used in research and literature and many clinical guidelines. However, these terms are not intended to exclude or individuate the experience of individuals who identify differently. I recognize and respect that some individuals prefer language such as birthing person, lactating parent, chest feeding, or body feeding. Throughout this presentation, all language referred to as mother's breastfeeding or the lactating body is intended to be inclusive for all individuals who experience pregnancy and lactation, regardless of gender identity or terminology that they choose for themselves. Lastly, for photos, I have received permission for all of the photos that are in this presentation. Some of these pictures that are shown show parts of the human breast, including but not limited to breast tissue, areola, or nipple. So why twin feeding needs a different frame? For families that are experiencing with pregnancy, carrying multiples, they have higher clinical risks. So most of the time, twin families are more likely to experience preterm birth, likeliness of cesarean birth, and sometimes NICU admissions. Two babies rarely feed identically, so each twin may differ in stamina, latch, transfer, weight, jaundice risk, and other medical needs. And parents need systems, not pressure. So routines, support, and realistic goals often matter as much as technique. So here are some statistics that we have. In the United States, overall cesarean birth rates for families with multiples is 60 to 75%. So this includes varieties including di-di, mono-di, and mono-mono. So with that breaking down often is how the babies are presenting during pregnancy. Although there are variations of mono-di where things are could be split. Generally speaking, di-di twins have separate sacs, separate placentas. Mono-di could have separate sacs, separate placentas, or they could share. And mono-mono, the rarer of the variations of twins, oftentimes have a shared sac or shared placenta. There's also different fetal presentations, gestational ages that they're born. For a family that potentially had a prior cesarean and is going for a trial of labor after cesarean or for their VBAC. Provider experience and availability. Some hospitals require specific staff for multiples, or if the family is intending to have a vaginal birth, depending on the presentation of baby A, which baby A is generally the baby that's closest to the cervix. So depending on how that is as well. And then as well as hospital policies. So with those different inclusions, we have a higher rate of cesareans for families with multiples. 6 in 10. So approximately 6 in 10 twins are born before 37 weeks. So prematurity is one of the most common clinical considerations in twin pregnancies. So with both of these two statistics in front of us, we know that there is a higher chance that the littles that we are hoping to feed are likely going to need some more individualized care or support. Twins are more likely than singletons to have a lower 5-minute APGAR score, largely because twins are more often born prematurely and at lower birth weights. So going back to that slide previously with the cesareans and the 6 and 10, sorry, that are born before 37 weeks, we have smaller babies. Those babies are maybe not hitting those developmental milestones. And we know with uterine growth and fetal growth, one of the last systems to completely mature is going to be the lungs. When babies are feeding, they need to be able to have that proper suck, breathe, and swallow pattern. And when we're just shy on the breathing part, it can kind of interrupt that system. And we have the 30% higher here. So, according to the study in PubMed, which I've linked below, it found that the risk of a 5-minute APGAR below 7 was approximately 3 times higher among twins than among singletons. So the second born twin also had a 30% higher risk than the first twin. So with APGAR scores, those are checking how the appearance, pulse, respiration, grimace, all of those appear on the baby at 1 minute and 5 minutes after birth. And this is for each individual baby in the dyad. With lower APGAR scores, this oftentimes is due to prematurity, babies having a harder time adjusting. And then when we have the second born having a 30% higher risk than the first one, we know that oftentimes that second twin can have some additional complications or needing additional support after. Some of the myths that we encourage to retire around multiple feeding. So you cannot make enough milk. So many parents can produce for twins when milk removal is early, frequent, and effective. Tandem feeding is required. So tandem feeding is useful for some families. Individual needs may be safer and easier at first. Supplementation means failure. So when medically indicated, supplementation can protect infant safety while supply is protected as well. So these are all things that oftentimes families hear when we are expecting multiples, some of the fears and challenges that we might have, but there are many ways to work around them and come up with a stable plan that works best for the individual family. So success starts before birth. So teach the first week plan. So colostrum, feeding cues, outputs, weight checks, normal newborn behaviors, and when to call providers. I highly advocate for families to take a twin or multiple specific childbirth education class. Know what is normal for multiples. This includes gestation when born. Yes, feeding cues can be the same as singletons. Generally speaking, they're the same. But when they're born a little bit early and we're looking at 2, coming up with a plan that works best. Discussing hand expression carefully. So antenatal milk expression may be considered only when appropriate and cleared by the pregnancy provider. For most families, it is safe around 37 weeks to start hand expression or antenatal milk expression. For families that have complications or higher risk pregnancies, that may be something that's discouraged. When discussing antenatal milk expression, something that I teach and advocate for very frequently, it's also very important to remember that what you are able to antenatally express does not define how your feeding journey is going to be. Some people have very low output with hand expression earlier on in the pregnant, or I should say later on in the pregnancy. Um, and once baby's born, placentas are born, and hormones adjust, then the mature milk is a lot more plentiful. Build the support and team early. So utilizing family doula support, having lactation on hand beforehand. So meeting prenatally, going over goals. Finding a pediatrician that works best with and aligns with your goals. If you're planning to give birth in a hospital that has a NICU, having the contact information. Also knowing what level NICU they are. For higher risk pregnancies with likeliness to give birth early, it's not completely uncommon for care to be transferred to a hospital with maybe a higher NICU status. Mental health providers, so advocating for having resources available for families that potentially need to have some mental health support, and really leaning into friends and family. So coming up with a postpartum plan. Do you have friends or family or a doula that can come stay with you in those early weeks to help navigate? Do you have someone that can help with household chores? Setting things up ahead of time can really lean in and make your transition home in those first few weeks and months a lot more manageable. So discussing birthing preferences that protect lactation. So before your admission into the hospital, so what happens if one or both of your babies go to the NICU? So when meeting with your pregnancy care team, oftentimes multiples are encouraged to meet with maternal fetal medicine. Having that discussion with your providers, with any specialists. Okay, what if I give birth and one of my baby goes to NICU or both do? How does that transition look for me and baby? Am I allowed to visit? Are there special rooms? Am I only going into one specific area? With families with NICU stays, oftentimes initiating lactation by pumping is it's not completely uncommon. Do they have those supplies there for you? Do they have the resources to help you? One of the local hospitals up here, I've had both doula clients and lactation clients. We have a specific area for families to stay that's not in the hospital, but affiliated with, so that they can be closer to their families. Can stable babies have immediate skin to skin? So, with all births, our hope is that baby is born and able to go in the birth giver or mom's chest. With that being said, we know the benefits of skin to skin. It helps regulate blood sugar, and it helps with their metabolism, helps regulate their temperature. All of the benefits of skin to skin are absolutely amazing for someone that has multiples. So we know that having one baby placed on the chest helps regulate their temperature. If you have two babies placed, your chest will differentiate temperatures to help bring them both to the level that they need. Do they have pumps or supplies on hand to help remove or express milk? And then when building into your preference list, your feeding goals and acceptive alternatives, including hand expression, a pumping plan if separated, or donor milk. So covering all of the bases, yes, it's sometimes over preparing for someone, but I would rather you cover and discuss these things and have a plan of your preferences ahead of time to help alleviate that if some of these ducks start to fall into a line where you feel a little less in control, having those preferences on hand can definitely help. Lastly, a clear supplementation criteria and a follow-up plan. So with each baby that is being born, they're very, very unique. And that is one of the things with families of multiples, twins, triplets, any more than that. Each baby is super unique to themselves and are going to have very unique goals and plans ahead of time. So when coming up with these, remembering that what may work for one might not work for the second. So in the first 72 hours matter. So keeping stable dyads together, utilizing skin to skin as soon as safely possible, including after cesarean birth when possible as well. If it is not completely possible in the operating room to have baby skin to skin on chest, ask if it's possible to do cheek to cheek with one or both babies. If it's not possible for that as well, if there is a partner or support person that is in the operating room or close by to see if the babies can also do skin to skin with them as well to help start those benefits. Feed or express early. So aiming for breastfeeding, chest feeding, body feeding, expressing milk promptly if either baby cannot latch effectively. So the earlier that initiation of lactation is initiated, that we can start that process of that lactogenesis too after baby's born, placenta's born, we're initiating lactation. The first 2 weeks really drive our supply, and the more frequent and efficient removal that we have, the better chance that there is. Tracking each baby separately. So their latches oftentimes are going to be different with how they feel, what they transfer. So we know going back a few slides, statistically speaking, baby B has potential lower APGAR scores. So it's not uncommon to hear that baby A is feeding a little bit more efficiently or has a stronger suck pattern than baby B. Their output. So what we're hoping that they get in, they're also voiding and stooling out. And then their feeding stamina. So we in a normal dyad, sometimes we have sleepy babies that we have to encourage by changing, burping, tickling their hands and feet, things like that to keep them stimulated. When you have multiples, if you have one feeding great and the other one you have to stimulate, or what if you're stimulating both? So just knowing that that first 72 hours after birth are really going to help drive your supply, keeping them close, bonding, and frequent removal really help with initiating that supply. Supplementation without undermining breastfeeding. So using medical indications. So we encourage to have baby at the breast or chest, encouraging that frequent removal, but we're also hoping for that efficient removal. So trying not to supplement by default because there are multiples, supplementing for infants or parents with those indications that there is something missing or there is a lack of. So if we are frequently removing either by hand expression pumping baby directly at the breast, that in itself is going to help drive that supply. Anytime we have a full breast, it decreases supply, empty breast, increase supply. So the more we remove, the more we make. Choosing the supplement intentionally. So if you do have to supplement, are you expressing colostrum or milk and offering that? Are you using donor milk or are you using formula? They may be used depending on the need and availability. And then protect milk production. So if babies receive supplements due to poor transfer or separation, creating a milk removal plan. So this oftentimes is for families that we have with NICU stays, coming up with that plan of how often we're removing, the time of removing. And one of the most important things with removal is making sure that we have a pump and a flange size that are correct and intentional for our bodies. So tandem feeding versus individual feeding. Tandem may help when both babies can latch and maintain stamina. Parent wants shorter feeding blocks. And positioning help is available early. Sometimes learning how to navigate getting one baby to the breast can be difficult when you have two and keeping them both latched efficiently at the same time. It can be a little bit of a learning curve. Having extra hands available, whether it's partner, friends, family, a lactation consultant, whoever it is that's with you to help navigate those early days, can really be beneficial to help gain confidence for your feeding when you're discharged home and then from there on out. Individual help when, so feeding individually when baby needs more support or pacing feeding, the parent is healing or overwhelmed, or if the transfer, airway, or latch, or if there's any concerns in need of assessment. So a few more statistics around families with multiples. So the 3.1. So in 2023, in the United States, the twin birth rate was approximately, 31.2. I knew that was off there. Births per 1,000 live births. Oh, no, right here. So it's equivalent to 3.1 of twin births, or yeah, of births being twins. So when we think of an overall big picture, it doesn't seem like a lot. As a multiple parent myself, it's one of those things where like you buy a car, you see all the same cars of yourself. When you're a parent of multiples, you seem to connect and navigate and catch up on a lot of those multiples as well. So 40 to 50%. So NICU admission among twins, about 40, 50% of twin newborns are admitted to the NICU or a special care nursery. So the studies for these two statistics here from the CDC and March of Dimes that I have linked below. So with feeding multiples, there is a very, very wide variety of positions to teach, not prescribe. So what works for one baby might not work for the other. What works at 9 a.m. might not work at 10 p.m. So it is super important when we're helping families or learning ourselves how to navigate feeding multiples to do what is most comfortable and sustaining for both the baby and the parent. In this picture here, it's depicted as a double football hold. So in this position can be helpful after cesarean or for smaller or late preterm babies. We can see that these two babies here are at the breast with their bodies tucked around the parent's side. With mixed holds, so we can see here that one of the babies is in a football hold and one in the cradle. There could also be one in cradle and one in laid back, or even one at the breast and the cradle and the other body feeding, or sorry, bottle feeding, or using a slide wide paced bottle feeds. So with babies with multiples specifically, there is no one size fits all. And if we are supplementing one, if one's directly at the breast, one's with the bottle, there's so many different variations of how to feed adequately and comfortably. I cannot um, say it enough to make sure that there is comfort. So when babies latch and they are suckling, and we are hoping for that letdown reflex to become more plentiful, babies start hopefully gulping and swallowing. Our bodies, when we are tense or have high stress levels, our bodies have a hard time letting down that letdown reflex. So when babies are at the breast for a period of time and it's holding back a little bit, sometimes we see that frustration. When we have babies that are little, preterm, have NICU stays, it's not uncommon for them to get fatigued very quick. So using supplemental nursing systems and different position changes to make sure that they're sustaining can be helpful. So in the double cradle hold, so in this position here, we can see that this person is using a double cradle. So both babies are being held in the arms kind of crossed over themselves. And then we can see here that this is more of that like laid back position where they're draped over the belly more, not necessarily quite in that cradle. Families also can do side lying positions with multiples, making sure that you're supported well on your side for the baby, and then have proper support for the second one that is likely going to be laying on top. So milk supply, build, protect, and adjust. So establishing with frequent effective milk removal, direct feeding, hand expression, pumping, or a combination may be appropriate. Responding to the pattern. So someone with low milk supply, there are some people that have hyperlactation, engorgement, mastitis spectrum. Um, all of these burn and require different care. So making sure that we are reaching out for the support when needed. So whether this is from your pregnancy care providers, your PCPs afterwards, lactation consultants, whoever it may be, if we have something, a variation that is off or different or requires additional support, that we're reaching out to the appropriate help. Triple feeding needs an exit plan. So this is something that I come across very frequently for families of multiples for various different reasons. Triple feeding is when someone is feeding at the breast or chest, and then expressing milk either by hand or by pump, and then feeding the pumped or expressed milk to the baby again. Most of the time, this triple feeding plan, when it is presented to a family, is for each feed to make sure that they are getting enough getting enough breast milk at each feed. So with triple feeding, it is used as a short-term bridge with constant reassessment. It is not an open-ended assignment. So this is not something that's supposed to go on for a long period of time. With triple feeding, so feeding at the breast, especially if it's taking a longer period of time, and then pumping for 15, 20 minutes, and then feeding, which can take another 15, 20 minutes. If we're doing that every 2.5 hours, it can feel nonstop. The main thing that I look at for a provider that is maybe suggesting this is maternal mental health, to make sure that there is a lot of support, as it can feel very draining, but that's why we keep it as a very short-term bridge. So, night needs and sleep expectations. So, one awake or both. So, oftentimes this is going to differ for each family individually, whether it is based on the age, weight, medical risk, or family capacity. For some families, it is best for them to keep on a wake window schedule, where if one baby is sleeping and one wakes to feed, that we wake the other to try to keep them in the same wake window and feeding window. But what happens if we have a baby that is gestationally weight-wise improportionate to the second one? Maybe we have a larger and a smaller baby. Their feeds may be different depending on their strength, and their wake windows might be different. So there is no exact one size fits all for these families, but I encourage you to make sure that there is support. So we're keeping on those frequent feedings to make sure babies are gaining well, but also that the parents are sustaining. So synchronizing when it helps, protecting sleep by feeding both babies during the wake window, and then separate when needed. So if there's poor transfer, jaundice, prematurity, fatigue, some of these require individual timing for those feeds. So with growth milestones, prematurity and NICU separation, so prioritizing human milk access, early expression, kangaroo care when possible, and discharge planning. So families that have NICU stays, um, I find that a lot of families that I come in contact with NICU support feel very supported when in the NICU. There's nurses, lactation that are there. Sometimes that transition home, though they feel happy to be home, that could be that little bit of a bridge of that support and the ability to lean back into. So coming up with a discharge plan to have traveling nurse or lactation follow up at home, follow up with a pediatrician to make sure that we're still having that bridge of care. Medical complexity. So some little ones may have low tone, respiratory issues, jaundice, hypoglycemia, or poor confirmation can change to feeding plans. So with little ones, really making sure it's individualized. Each baby is individual to itself. Relactation and transition are possible. So progress might look like one direct feed and one less pump, or a calmer routine. So you can work on exclusivity. So there is no one size fits all. Some families are able to exclusively directly feed at the breast. Some have to come up with a schedule that works best for them. And oftentimes I find this revolves around sleep to make sure that the family is thriving. Using any form of supplementation to be able to maintain the current supply that you have is, whatever your plan is amazing for you or your clients that you may have, making sure that we're hitting all of the check marks that we're really hoping for. So when one twin's different than the other, so making sure to assess each baby as an individual, comparing patterns without assuming the stronger feed reflects the whole dyad and vice versa. With a singleton, as an IBCLC, I always recommend feeding at both breasts each feed. So when we have multiples, common questions that I get are, should I always feed baby A on right breast and baby B on left, or vice versa? Normally, my clinical recommendation is to swap them. It is very common that one baby is going to be a little bit more efficient and one maybe not. And if we are swapping them, we're making sure that the breast has the ability to drain or have the milk removed efficiently. Tracking each baby as an individual. So making sure that if we are documenting things like weight and output, milk transfer, that we do have two separate little pieces of paper, or if you're using an app that is specific to multiples. When tracking, I always say use it as a tool. And if we find that our mental health is struggling because we are obsessing over these, to reach out for support. It's not uncommon for it to be very easy for us to monitor, and if we see a change, to assume. And then avoiding equal plans for unequal needs. If one baby needs a little bit more bottles, supplementation, time at the breast, practice, or special support. So just making sure that we are keeping those babies' needs individual. So when to bring in the team. So IBCLC, so International Board Certified Lactation Consultant. So they can help with pain at the breast, poor transfer, low supply, pumping plans, supplementation, and relactation. Some feeding specialties. So if we have babies with oral motor function, hypotone, airway, or coordination concerns, sometimes speech language pathologists or occupational therapists can also weigh in those. If we have weight concerns, jaundice, dehydration, or concerns around prematurity, the pediatricians can be an amazing resource. Postpartum doula, so they can help. Oh, I apologize there. That shouldn't be there. So doulas, they can help with organization, taking the weight off of coordination around the home and alleviate some stress. And then last, we have the mental health professionals. So they can help with feelings of anxiety or depression, discussing trauma. So this could be birth trauma, even feeding trauma afterwards, sleep deprivation, if someone's having thoughts of inadequacy, self-harm to yourself or baby. So these are all super important things to make note of when we have lactation providers, pediatricians, and either partners or support people. These are going to oftentimes be the first people, the first line of defense that are noticing these changes, these subtle changes, and can offer immensely sooner support to make sure that we are supporting the family. So 43%. So mothers of multiples had a 43% greater odds to moderate to severe depressive symptoms at 9 months postpartum. So the Below Link study from PubMed, based out of the United States, published in Pediatrics, compared mothers of multiples with mothers of singletons after adjustment for maternal characteristics, child health, relationship status, and socioeconomic factors. Mothers of multiples had a 43% greater odds of moderate to severe depressive symptoms at 9 months postpartum. So we statistically know that families with multiples oftentimes have higher odds. Making sure that we as providers are asking the questions. And I say asking the questions and not just handing out the forms. I'm 100% honest. I'm a mama of four. There have been times where I probably didn't fill them out the most truthful. But if a provider had asked me a specific question, I know personally I probably would have answered it a lot clearer than I would have documented it on paper. So helping the entire family thrive. So assessing each baby as an individual, comparing patterns without assuming stronger feeding reflects the whole dyad. Protecting the parent. So screening for mood symptoms, birth trauma, feeding trauma, sleep deprivation, unrealistic expectations. Using the village intentionally. So partners, grandparents, extended family, doulas, community groups, meal support, and scheduled follow-ups. So these are vague, but just to get our brain jogging a little bit here. So case study number one, scenario, we have a 36-week-old dyad born via cesarean. Twin A transfers milk well. Twin B is sleepy with poor transfer. So what are the things that are coming to mind when we're discussing? So what is the first priority? Who do we recommend? Would we recommend pumping, or would you supplement or refer? So each family is going to be very different depending on different factors here. So we know statistically speaking, at 36 weeks, that is preterm. via cesarean birth. So babies with cesarean birth statistically have lower APGAR scores, and we know that out of twins, baby B has oftentimes lower APGAR scores than baby A, which reflects with the two statements potentially that baby A is transferring a little bit better than baby B. So the first priority, what are we thinking? Are we thinking, okay, we have premature babies born at 36 weeks via cesarean. So we have the healing parent. With cesarean births, it's not uncommon for lactogenesis too, so the initiation of that milk to be delayed. So statistically speaking, for families, vaginal and complicated births, we're potentially seeing that mature milk presenting day 3, 4, 5, maybe. If we have a cesarean birth and if there were any other medications potentially used, we know that that could be pushed back some. And when we're feeding two babies, we're trying to keep them at the breast. Okay, going back to baby A and baby B transferring. So the first thing clinically I'm thinking is, okay, we have a baby that's not transferring as well. What are the things that we're doing to help? Are we keeping stimulated? With the two, are we switching breaths? Are we pumping at all? Is the family hoping to pump? How are the things that we're going to clinically go through? So walking through these different steps with each family can help them come up with a greater plan to be able to make it more sustaining. Case study 2. So scenario, a 4-week-old twins after having a 3-week NICU stay. The parent is exclusively pumping and the parent wants to try nursing but feels burnt out. So what are the things that we're discussing? So what is achievable this week? When I look at the scenario and I'm reading these things that are here, 4-week-old twins were in the NICU for 3 weeks. So this means they've potentially been home for 1 week. Um, One thing that we don't know here is how old are they? What gestation were they born at? Were they full term? And maybe there was something a little bit underlying that initiated the NICU stay, or were these babies born at 35 weeks? Like that is one thing that this case study doesn't tell us. But when we're thinking of clinical things, how are we brainstorming? So this parent is exclusively pumping. So I'm going to assume that the parent started pumping while in the NICU to initiate their lactation supply. What is their supply at? How are babies transferring? And then we want to try nursing but feel burnt out. So, what are ways that we can help with lightening the load? Even if we are attempting to latch once a day, even one baby once a day, that is a huge milestone of getting the baby to the breast. Normally, what I would encourage is um, skin to skin. That's an amazing way to start off with how to bring baby back to breast. So, what is achievable this week? Let's take it slow. Let's try to lighten a load. Let's see what realistic plans can be. How can bottles and breast practices coexist? So, do we have someone helping feeding? Could we spend some time with one and then the other? And then what support prevents burnout? So, having partner support, having family support, doula support, finding your village. And I say find your village as a millennial that is going through all the things with many others with that village. Like, where is it, right? Um, Sometimes it's literally community groups, breastfeeding support groups, postpartum support groups, that where you're finding people in the similar um, rowboat that you're in and working and networking this together. Sometimes just physically speaking out loud to another human being can relieve a bit. So, final takeaway and some resources. So, twin lactation care is family care. So, it's really important to make sure that we are taking care of the entire family, not just the babies. So, moving beyond the latch and milk transfer to safety, supply, sustainability, and emotional well being. Using evidence-based resources. So, the American Breastfeeding Medicine Protocols, American Academy of Pediatric Breastfeeding Policy, World Health Organization 10 steps, CDC data, and local referral pathways. And these could be included to not limited to different support groups, La Leche League, Baby Cafe. So there are many resources to help get that groundwork going. And then it's super important as providers to remember that leaving families with confidence. So small and timely interventions can help prevent bigger feeding crises when crises and help families thrive. So that is the end of my presentation here. So I had Twice the Love, Twice the Latch, helping families thrive with twins. So families don't need perfect providers. They need providers who believe in them before they believe in themselves. Here, I do share pictures of my first time, my twins latching, tandem feeding. Um, I believe they were within 12 hours old at that point. And then their very last feeding when they were 24 months.
Awesome. Thank you so much, Ashley. That was a great overview of how to best support these families who have more than one newborn baby. And I love how you kind of ended that with, I love the quote, first of all, but how important it is to leave families with confidence and like that being the ultimate goal. And helping to support them with their goals, of course. But that confidence piece is critical, and that there's the importance of balancing all of the needs that include the mental health needs and making sure when you're setting goals that they are achievable and reasonable. I think that's really important. And I'm sure that's something that everyone here also believes in as well. What questions do folks have for Ashley? It's great to have some of those case studies and scenarios. Are there specific questions or issues that you've all had, challenges you've had with supporting families with twins that Ashley might be able to help you with? We have some time for more questions or for any questions. I will also drop in the evaluation. Okay, Erin has a question. You recommended twin breastfeeding specific prenatal classes. Are there any in particular that you recommend?
So I am someone who very firmly believes that face-to-face and hands-on support is strongest for families. First, I would normally recommend and see who, if there are any twin specific or multiple specific lactation professionals near you before resourcing and going online. With the ones online, just making sure that they are adequately trained professionals. Although, yes, lived-in experience is totally super helpful, but just making sure that there are adequate ones that we're reaching out to.
Thank you. And Crystal is asking, what are the biggest challenges parents of multiples uh, are reported? I'm not sure if Crystal, if I'm reading that right. What are the most common challenges that they're reporting to you or coming to IBCLCs for?
Yeah, so me personally speaking of families that I've supported, some common things that I hear. One of the most is lack of support. Not necessarily with family or friends, but when they're leaving the hospital, there's that in between period of having pediatrician appointments or lactation consultations, meeting with other providers, just making that they feel a little bit lack of support is one of the common ones that I hear. Um, Another one that I commonly hear are coming home with specific plans, how to feed both of their little ones, and not necessarily a follow-up plan to how to change that. So some people come to me with, what is next? How are we changing this? Is this sustainable? So those are a couple of the common ones off the top of my head that I see.
That's helpful. And also thinking about Zip Milk is a lactation directory that some states are using. And I was just looking to see if multiple support is something that someone could check. And I don't see that, but I think that people could add that to their listing. And that is a keyword you could probably search for if you're
Mhm.
looking for someone who has experience with that. So if you consider yourself someone who has experience with multiples, that's something you might want to add to your listing if you're on Zip Milk. Erin, okay, Full Hearts Collaborative is the lactation consultant twin expert use. Are they local, Erin, or is this virtual support? Okay. Yeah, if you have a link and Ashley too, I don't know if your link to your website, if you want to drop that in the chat, that's great for prenatal classes. Thanks, Erin. And then Madison says, I'm wondering what the best latching positions for twins are, especially when you need help keeping one or both babies latched. I know everyone has different preferences and they change over time, but I feel like this is something so many families struggle with.
It is so very individualized for each family and each baby, so it's kind of hard. But yes, I find that when twins are smaller, some families find it easiest with the football because they can tuck and visibly see. When we have that ability to initiate that effective latch, so making sure that the nipple is stimulating the roof of the mouth, that we're getting that really big opening. They're able to draw back as much breast tissue, and then we have the chin planted very well with a larger opening in their neck so that their airway is great. When we can get that effective latch with those things there, the position isn't necessarily specific. We just want to make sure it's efficient, it's comfortable, we're not causing any damage to the breast, and kind of going from there. As babies get a little bit bigger, it gets harder to tuck them. That's when we get a little bit more creative with positioning. I find that the least favorite for myself personally and some families that I've supported is probably the double cradle, finding how to navigate having them tucked on top of each other without them kind of wiggling around gets a little creative.
Well, thank you. And then what is your opinion about pre-colostrum with the babies?
I am a firm advocate for if it is medically safe to express to have it with you. In my prenatal consultations for my in-person clients, I send them home with prenatal kits for antenatal expression and encourage if you have the time to try to express them, obviously cleared with your medical professional, bringing it in with you, bring it in labeled into your birthing location. Say, I have this with me in case there is a separation, or if I need to supplement. You already have your milk there, and yeah.
Thank you. Aaron, I was going to ask that same question and I was afraid I'd missed it because I was distracted with some keeping track of attendance and all that. But do you have a favorite breastfeeding pillow? And then I'll go back to the other questions too.
Yeah, a lot of families commonly I find use the My Breast Friend twin. So it is larger, it lays flat. Oftentimes, grabbing whether it's a pillow on your sofa, bed, whatever it is, all I recommend is that we're keeping baby up to breast level, especially when we have to. If we are hunched over trying to feed, it causes so much strain on the back and the nerves. With the Breast Friend twin pillow, it lays flatter. Oftentimes, what I'll have families do, especially using in the football position. So like I have two of my dolls here. So if I have them at breast and have a pillow, if the pillow is lower, putting another pillow underneath to be able to lift it up higher so that we have baby up at breast level and we're not hanging down low.
Great. And Emily also had asked about best baby wearing for twins.
Ooh, that's so I love baby wearing. Every carrier is going to be a little bit different depending on the safety and baby size. So some stretchy carriers, so this could be like your Moby, um, any of the stretchy form are sometimes easier when they're little to be able to kind of tuck them in. As they get bigger and have a little bit more support of their back, their posture, their airway, using other different carriers that have the ability to so there's like double ring slings where you can have them both on either side, and when they get larger you can have, there's front and back carriers. I don't find there's any one specific that is way better than the other, but they do have multiple brands that are twin specific. They're normally a bit pricier obviously because you have two.
Yeah, if anyone has any recommendations for online resources for baby wearing, please drop those in the chat, specific to twins or not.
Mhm.
And Erin's suggesting Facebook Marketplace for finding some baby wearing, some wraps and carriers. Good call. And then Jennifer Ann had asked, how do you decide the exact amount of supplements in ounces a baby needs, breast milk or formula, who is not reaching appropriate weight gain, if this is alongside another provider with a long-term plan to wean? That's a big question, and it's almost like a whole other webinar, right? Because there's a lot of factors, but if you want to
Sure.
answer that, Ashley, as you would as you would. Go for it.
Yeah, there's definitely a lot of parts to break down in there. So kind of breaking it down a little bit. So there sometimes that formula that we use to how old baby is, what they should be transferring, depending on their age and weight. So that's like one specific thing. If they're not necessarily meeting weight gaining goals, oftentimes we're looking for different things. So is it transfer? Is it motor function? What is the reasoning why that we're not getting it? Starting there at least. And alongside another provider with a long-term plan to wean. So I guess that also kind of depends on the age. What age are you hoping to wean at? Where are you at in your feeding journey? So it's kind of without going into like specific care plan details, like there's definitely multiple parts in that question there.
Madison's sharing your baby wearing bestie has an excellent Instagram of so many wraps for twins and singletons. She also shares some brands and custom wraps as well. That's great. I'll write that down because I feel like I have not seen a lot of baby wearing resources or education lately, and it's
Yeah.
so important.
So
And
I
I'm
took my
just
training through the Center for Baby Wearing Studies. They do have a multiple specific class, I believe, on there. Sometimes reaching out into a local, whether it's mom groups or however it may be. I know that there's one in my community that I reach out to and collaborate with. At my office here in New Hampshire, I have an entire library, and I think I have five or six twin specific carriers that I have for families and multiples that can come and try them on.
so Jennifer, thanks for your comment. When to wean and when to wean the supplementation. Yeah. So our conference last fall, we had a presentation about supplementation and when and how much and all of that. And that recording is available on our website. So on our YouTube page rather. And I'm not sure I can find it as quickly as I would like to right now, but I think if you go to our website, mainbreastfeeds.org, you can find that. And I think it was really good session. But we're at 1 o'clock. So thank you all so much for being here. Thank you, Ashley, for providing this excellent webinar. And we will be in touch with certificates and evaluations and all of that. So I hope to see you all again and have a wonderful rest of your day.